Hello and welcome to today's webinar, Cervical Cancer Reimagined, is first-line treatment on the verge of transformation. I'm Aisha McClellan, the Cervical Cancer Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancers and provides outreach to the general public on signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, and helplines, please visit sharecancersupport.org. We are very excited to have Dr. Monk joining us today, and I'd now like to hand it over to Dr. Monk to introduce himself.
That's great. Thank you. It's my pleasure to be with you guys today. I'm a big fan of Share, as I, no pun intended, share my screen. And it's really a pleasure, and you guys do great work, and I'm just really honored to be hosted here. I'm very passionate about cervical cancer. As a young man, I was told that cervical cancer, when it recurs, was uniformly lethal, and that it was not responsive to chemotherapy. And quite frankly, that made me angry, pissed me off. And so I have sort of devoted much of my adult life to proving that wrong. Also, as part of my journey, I grew up in Arizona, is that the Latina population there is really impacted. And so really before diversity was a thing, I became passionate about all women. I know that sounds crazy, but yeah, all women. And so I'm really a pleasure to be here. I'm in West Palm Beach. I have a couple of different jobs. There's a nonprofit organization called the GOG Partners, which I founded in 2010. I continue to be the director of that. Being passionate about cervical cancer, I chaired the cervical cancer subcommittee for the National Cancer Institute, the NIH, for 11 years. And also the Gynecologic Cancer Intergroup Cervical Cancer Committee. Now I run clinical trials for the state of Florida, Florida Cancer Specialists and Research Institute, and I'm here in West Palm Beach. So I want to augment your knowledge. You wouldn't be here if you didn't have some knowledge. I want to share some of my tips. Again, I'm not always right, clearly, but I've treated a number of patients, and I think I have some insight as to the best way to help women live better and live longer. It's not enough to stay alive, but we have to keep ourselves safe and live well. And I want to equip you as well. So I thought I would start basic. I think that's the best place to start, is in the beginning. So what is the cervix? The cervix is part of the uterus. This is the body, holds the baby. The cervix is the opening, and this is the top of the vagina. And you can see here on a cartoon. Now, I need to begin and say that cervical cancer should never happen, ever, because you can receive a vaccination against the virus, the human papillomavirus, which is almost 100% effective, and it can be given in young girls and boys before their sexual debut, generally recommended around 11 or 12, but up to age 26, but even reimbursed sometimes up to 45. And you can get screened, and the way you screen, you look for the virus, because if you don't have the virus, you're not going to die of it. And certainly smoking and safe sexual practices. Now, you have to have sex. No, that's not true, to have a baby, because I guess you could have it through artificial methods. But being promiscuous and sexually deviant is not associated with cervical cancer. It's true that most women that get it have had sexual relations, as has my mother, and at least twice, because I have a brother, and there's nothing ever that my mother could do wrong, in my opinion. So I just want to get that out there. My residents and trainees call this a cauliflower lesion. This is looking into the vagina, but it's cut out. This is a radical hysterectomy. A radical hysterectomy is more than a simple hysterectomy. People think radical means removal of the ovaries and the fallopian tubes. No, what it is it's removal of the upper vagina. You see this cuff and the paracervical soft tissue, sometimes called the parametrium. This patient was cured with this operation, but you can see this and you'll never eat cauliflower the same again. This is the uterus again from a side view. This patient cut in half. You can see this mass, which is every bit as large as the uterus. That here white, this is the tailbone. This is the pubic bone. If you can just imagine cutting a patient and looking. And this patient's also cured. This cancer was too large for surgical resection. This is the bladder. This is the colon. The cervix is between the colon and the bladder. This patient was also cured, but chemotherapy and radiation. Okay, it's too big to cut out. We prefer to avoid chemotherapy and radiation because it might have minor long-lasting effects. That's why this is the preferred method, surgery, for being early diagnosed. Now, this is an illness, a malady of international proportion. The number of cases in this country has remained relatively stable at about 14,000, with about 3,000 to 4,000 deaths because we can't figure out how to get vaccinated. Okay. But the vaccine has been around since 2006 for 18 years. But what this shows that say in North America and Europe, most patients are in the lower risk surgical opportunity. But in the locally advanced setting where surgery is not an option, let's say 26% in Europe and 38% in North America, where patients would need chemotherapy and radiation. So it's more common internationally, yes. And it's more advanced stages internationally. So here in Africa, almost all the patients, 88% of the patients cannot have a surgery because it's too big. Not that they would have the surgical expertise anyways. And this also shows some Eastern European and Asian as well. But I just wanted to provide some of the demographics regarding this. Now, the discovery has been twofold. Is that when I looked at a cervical cancer as a young man, my professor said, look, Monk, the way you tell that this is a cervical cancer is it's bloody. Like, what do you mean? Well, the blood vessels are feeding the cancer. So I sort of had the opportunity working with my friends to show that if we could interact with the vasculature, the angiogenesis, and give an anti-angiogenic, that we could cure more patients. And then the second discovery that we made is that if we can teach the immune system to kill the cancer, we reprogram it, we could kill the cancer as well. So your immune system wants to kill your cancer, whether it be cervical cancer or other cancers. The immune cells wants to make this go away, and we can give chemotherapy and radiation, but it's not always effective. But if we can reprogram the immune system through immunotherapy, and that has sort of been the epiphany, the discovery, the evolution, hence the name of this presentation, we've changed the world together. And in these studies, most of them have been through the nonprofit organization that I founded called the GOG Partners Organization. That's my backdrop. And so I'm going to share with you clinical trials that women and their families supported, as well as pharmaceutical companies, because they have the medicines to cure more patients. So if I was to sort of boil it down on one slide, these are the 6 practice-changing, change the world. Phase 3 means we take what we're doing and we randomize to a different treatment to help women live longer and live better. So in 1999, right after I finished my training, we showed that when radiation is given for an unresectable, locally advanced cancer, that you can add platinum. Yes, the same metal that jewelry is made of. It can be solubilized, injected, and it can bind to the DNA of the cancer cell and kill it, and also make radiation work better. This was the first discovery. And then on behalf of the GOG, I had the honor of presenting the addition of cisplatin, which can be used in the recurrent setting, but also this medication called Taxol, which is from a conifer, the Pacific yew tree in the Northwest, Washington State, for example. And it's part of the bark of the tree. It's part of the bark of the tree to protect it from the insects. Oh, look at that. And initially we cut down a lot of trees terribly and affected some squirrels, not kidding. And then we got it from the pine needles, and now it's synthetic. And now the standard chemotherapy backbone since 2009 is platinum in a liquid form, cisplatin, and paclitaxel, which used to be called Taxol, but now it's generic. And then in 2014, we added an antibody that binds the hormone that makes the blood vessels grow, bevacizumab. Changed the world again. Okay. And so before 2009, patients were sort of living in the recurrent setting, and I'll show about 7 months. We've been able to iteratively improve that. What we call the front line, which is the title, is patients who walk through the door and have a 4B cancer, or they have persistent disease, they get radiated and it doesn't go away, or they have a surgery or radiation and it recurs. And all that is lumped into a term that I coined first line. Now, some people say, well, what do you mean? Isn't chemotherapy and radiation first line? Well, there's maybe, and I'll touch base on this a little bit. But generally, by first line, we mean stage 4B persistent or recurrent cervical cancer, which started out as chemotherapy and added an antibody to make the blood vessels not feed the cancer. Okay. And then ultimately immune therapy to help your immune system kill it. And then if that doesn't work, published in the New England Journal just on July 3rd, 8 days ago, you can add now an antibody drug conjugate. An antibody will stick to the tumor and bring on the back of the antibody a payload, a chemotherapy, and enrich in the tumor microenvironment a cytotoxic chemotherapeutic agent, preferentially to the tumor. And that was published in the New England Journal on July 3rd. And that was FDA approved on April 29th of this year. So these are really game changers. And now what happens is that, again, the GOG and my friends said, well, look, Monk, you did all this work with immune therapy in recurrent, persistent, or stage 4B. Why don't you add it to chemotherapy and radiation? Why don't you add it here? Oh, we did. That was approved on January 12th of this year. So we've had 2 FDA approvals of an antibody drug conjugate in the second line, chemotherapy and radiation in the curable setting, and then this was approved in 2021. This is what you call innovation in scientific process, scientific innovation and progress, I mean, as a team. So immune therapy actually started in the second line. We live in a country where we can get medications approved in an accelerated approval process. And what that means is that you can do a small study in this setting, 77 patients, and you can shrink tumors in a high unmet medical need, and you can get it to the market here in 2018. But the FDA says, look, that's preliminary, got to prove it. So we got it approved in the second line as a single agent, and then ultimately regular approval, and with bevacizumab, and now, as I said, in January, can add it to chemotherapy and radiation. We have other immune therapies. I skipped over that slide. Another one, which is a similar agent, is approved in other parts of the world. And this particular agent is very common in the PMDA, which is Japan. There are other immune therapies which are not approved. Just for the sake of time, I'm not going to get into them, but there are studies of durvalumab and a very nice positive study of atezolizumab. So this is what I'm talking about. So again, when I was a younger man, I was told that cervical cancer was not sensitive to chemotherapy, and those women, on average, at an age of about 49, 50, would live 7 months with stage 4B persistent or recurrent. 7 months, 48-year-old, generally kids in the household. And then in 2004, I said, oh, then we added paclitaxel and cisplatin. We're able, and I get it, 7 to 12.9 is not enough. But we showed that we could actually shrink tumors in the recurrent setting 29% of the time. Again, not enough. And I did not give up. So then we added this antibody that chokes off the blood vessels, and we increased it from 12.9 to 17.5, and we almost doubled the response rate to 58%. This is 2014, 2009, 2014. And then in 2021, we even got better by adding and just piling on immune therapy. And now the tumor shrinkage rate was 69%, and patients were living more than 2 years. Oh. And then I discussed the publication on July 3rd of the antibody drug conjugate and the FDA approval on April 29th, and they can live another year after this. And so patients now with recurrent cervical cancer are living on average 3 years. And I'll show you that we can actually cure them more often, which is our ultimate goal. So I'm going to sort of skip ahead for the sake of time. I want to leave time for you can download these slides and we'll share them with you. These are the scientific data that go through all the curves and all of that. But it's FDA approved, and you can read about it in the New England Journal, which is the top medical journal in the world, that added both bevacizumab in the recurrent setting and pembrolizumab. But I wanted to sort of put this into the real scenario. Okay, and this is a woman, generally cervical cancer is in age 50, but this woman's hasn't had a PAP for 10 years. Why should she? She went through the menopause, she's done having kids. Why go to the gynecologist? Well, because you might die from cervical cancer. If we've learned anything from COVID, if you don't get vaccinated, you might die. And if you want to know what your risk is, get a COVID test. This is exactly what I've been trying to teach for decades. If you don't get vaccinated, you will die of cervical cancer or head and neck cancer or penile, anal, and vulvar cancer, which are all HPV related. And if you want to know if you're going to get it, get a viral test. So she has that and had a big tumor growing into the bladder, and she can't have it cut out. So what should she get? Chemotherapy and radiation. And what should she really get? Well, since January, and this is I'm going to actually show you these curves, she should get immune therapy with it. FDA approved, reimbursed, recommended by the consensus guidelines. The consensus guidelines are called NCCN, National Comprehensive Cancer Network. And you can go on the NCCN website. You have to register. It's free. And you can download the NCCN recommendations for any cancer. And so you can print them out or get them. There's even an app, and you can figure out what the best way is to treat cervical cancer. And the NCCN says this patient needs chemotherapy, radiation, and immune therapy. And it's not being done. Why? It's a great question. One of the challenges, when you get a serious illness is that you go to someone that's convenient. You go to someone that may or may not be expert. The most important decision that you'll ever make if you get a serious illness is picking your doctor, because your doctor will choose your treatment path. So this is the newest and the greatest. This is the last FDA approval that we had. This is January 12th FDA approval. We took patients just like this hypothetical patient who had a big tumor growing into her bladder and treated her with cisplatin and radiation that we established in 1999, and randomized patients, 1,000 patients around the world, GOG, and our European friends, which is called NGOT, and half got pembrolizumab immune therapy and half didn't, because we wanted to cure more patients. We had already showed in 2018 that it works in the second line. We already showed and got FDA approval in 2021 that it works in the first line. Let's give it with chemotherapy and radiation. It's a no-brainer, right? Well, that's what I thought. And we won. And published in the Lancet. The Lancet is the New England Journal equivalent in the UK. I won't go through the details other than to show that when you look at these curves, these are called Kaplan-Meier curves. So in the beginning, everyone's alive, time 0, everyone's alive, 100%. And over time, patients die, okay? And this is the placebo arm. This is chemotherapy and radiation alone. And this is the patients that got immune therapy called pembrolizumab, an antibody against PD-L1 or PD-1. And if you compare this curve to that curve, this curve is 30% better. The dark Pembro curve is 30% better. The hazard ratio is 0.7. So again, 0.7 minus 1 is 0.3, or a 30% difference. So at any time along their disease course, you have a 30% chance of being alive versus dead if you get immune therapy. Now, this is what the study showed. You may say this is not a big discriminator. And in fact, the FDA sort of felt that it should be used in the highest risk patients And in the highest risk patients, the hazard ratio went from 0.7 to 0.59. And this is the FDA indication. And if you read what I write or follow the GOG on Instagram or Twitter or LinkedIn, you'll see that I'm pretty agitated about this because I wanted everybody to get it that was eligible for the clinical trial. Listen, we studied it in this group of patients. It worked. Why are you going to slice up the pie? How dare you tell someone that you don't have cancer that's bad enough to get the best treatment? Well, that's what the FDA said. And so you have to have all the way invading the pelvic sidewall, blocking your kidney, or like in our hypothetical patient, invading into your bladder or your rectum to get pembrolizumab since the FDA approval on January 12th. So there's side effects. The immune system that we're educating can get so revved up that you can affect normal tissue. You can affect the lungs, can even cause thyroid, intestine, and other, even a rash. These severe adverse events happen around 1 in 25%. They can be reversed because if the immune system's too active, give a little immunosuppression, calm things down. But this, I think, justifies the benefit moving forward. So back to our patient, this patient should get chemotherapy, radiation, and pembrolizumab. Okay. So this is innovation. This is clinical trials. This is the GOG. This is working with a drug company. They have the medications. It's not that we're making all this money from the drug company, but we're curing all these patients with the medications that are made by this particular medication. So I'm going to end a little bit more about me. I work for Florida Cancer Specialists. We have 100 offices in Florida. We have more than 270 doctors. And why does that matter? And each one of these dots is where there is an office in Florida Cancer Specialists. Now, we're not in Miami. We're not in Fort Lauderdale. There's a doctor on every corner. But we're up in here. We're up along the coast, Daytona, okay? This is Tampa. There's some unmet need in Orlando. Why is that important? That's important because most of our patients live within 20 miles of our offices. Why does that matter? Remember, I'm going to come back to diversity. Marginalized populations can't weave through Jacksonville and get to the Mayo Clinic. In fact, the Mayo Clinic doesn't even take Medicaid. But we do. And we're woven throughout the fabric. And we're committed to research, and we're committed to seeing patients quickly with high quality. And I'm not trying to be negative to the other practices in Florida, although we are the dominant practice. I'm trying to preach, yes, preach, that we need to bring medicine to the patient rather than have the patient get in the car and drive 2 hours. Yes, even in rural America. Yes, even if you're a single mom. Yes, even if you don't speak English. Okay, and that's my passion. And so we have hundreds of trials open. We enroll hundreds of patients, and that's my passion. And I'm here to help anyone. There was no conflict of interest. I didn't show you a conflict of interest slide. I'm doing this for free. No one's paying me to do this. And this is my passion, and this is my life. And I really appreciate this opportunity. Thank you for having me today.
Thank you so much. Your passion shines through, and I just really appreciate all that you do, and I'm very grateful. Thank you. Let's start the Q&A. There were a lot of pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen. We'll try to get through as many as we can with the remaining time. About 5 minutes, so let's see. Rapid fire questions. Do you consider any of the treatments currently used in cervical cancer treatment to do more harm than good?
No.
Okay.
I mean, yes, there's harm.
Yeah.
But you have to be alive to have a complication.
Fair.
Every patient that's dead never has a complication, other than they died of their cancer. Now, if the treatment was killing the patient, that's a different story, but these are not treatments that have death as a risk for all intents and purposes.
Right. How do newer treatments for cervical cancer compare to traditional chemotherapy? Are they easier to tolerate?
100%. They're antibodies. They're
Right.
not platinum. Heavy metals are poisonous. You ever heard of lead poisoning? Okay.
Mhm.
And the reason that your hair falls out with Taxol is because it kills rapidly growing cells, such as your hair. So the targeted therapies, or we say, are antibodies, all of them, pembrolizumab, bevacizumab, even the antibody drug conjugates. So yes, and so as I said several times, our goal is, yes, to cure more patients, but in addition to keeping them alive, we have to keep them safe and well.
Right. What are the main challenges patients face with with current treatments for cervical cancer?
Economics.
Mm.
So again, I'm from Arizona. About half of the patients in Arizona that get cervical cancer don't have any funding.
Mm.
The county hospital in Phoenix doesn't even have radiation. You don't have to go to Africa to be treated in a hospital that doesn't have radiation.
Right.
You just need to go to Phoenix.
Mm-hmm.
And so our healthcare system is broken.
Yeah.
And we do not take care of the Americans or even those that are in America and they're not underfunded. So that is the biggest challenge. The
Mm-hmm.
second biggest challenge is aligning yourself with a doctor that's elite. I'm a sports fanatic. You know, there's LeBron James and then there's non-LeBron, the son Bronny. Okay. And they're different. And you have no idea when you go to your doctor whether your doctor is LeBron James or Bronny James. And so how do you know? Well, you talk to your friends, and I'm a big fan of specialty care.
Mm-hmm.
So I have a sore shoulder, for example. If I ever get my shoulder operated on, I'm going to get my shoulder operated on by a world famous shoulder surgeon.
Right.
I'm not going to go to the orthopedic surgeon that works around the corner.
Mm-hmm.
Because my shoulder is pretty important to me, right?
Right.
But people think that every doctor is the same.
Mm-hmm.
Go ahead.
Yeah. What do genetic tests have to do with my cervical cancer treatment? How might they personalize my care?
So for all intents and purposes, cervical cancer does not run in families. You may say, well, my sister got cervical cancer. You're right, because your sister has the same challenges in getting a pap test or getting vaccination or smoking or lives in rural America, all of those things. And they're related, but it's not genetic. So the short answer is nothing. Now, maybe you mean molecular markers. There are new treatments that are being developed. And in addition to what I described as the treatment paradigm, you should have in sort of the later line your tumor profiled. It's not the genes you were born with, but it's the genes in the tumor. And we can sort of figure out some rare genetic mutations in the tumor. You weren't born with them, you developed them, that we can interact and kill your cancer. So again, that's part of the standard treatment. I have time to get into that, but that's what experts do. And so, for example, you should ask how many cervical cancer patients do you treat in a week?
Mm-hmm.
And if it's not double digit, run.
Mm. Good point. Good point. Well, this was great. Oh, last question. Sorry. What is your biggest takeaway for patients?
My biggest takeaway is get the best healthcare you can. The Affordable Care Act has been transformational. Everybody thinks they're different, that they don't need insurance until they do. And also see the best physician that you can see. I'm a gynecologic oncologist for one reason.
Mm-hmm.
Gynecologic oncology is the only specialty in medicine that specializes in cancer. A radiation oncologist specializes in radiation.
Right.
A medical oncologist specializes in medicines.
Mm-hmm.
I specialize in gynecologic cancer. I know more about cervical and ovarian cancer because I'm trained in it.
Yeah.
It's not that I'm smarter, but I'm
Sure.
trained in it. and I talk to my friends. So you can, whoever our listeners are, you probably say, hey, I live in Omaha. I said, oh, I know. I don't know why Omaha. Robin Farias Eisner is the chair of Creighton University, is a gynecologist. He's very good. But we're a club, we're a team, and we all talk, and we'll do anything to help our women stay alive and live well.
I love that. Thank you so much, Dr. Monk, for an informative program. Thank you.
Thank you.
Thank you to everyone for participating and submitting questions. Please make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media. This concludes the webinar. Thank you all so much.
Thank you.
Have a great day.